Hi, this is Brian Kim. I'd like to share with you my modification of the Yamane technique called Trailing-Haptic-First. This technique has been accepted for publication in the upcoming either April or May 2018 issue of the Journal of Cataract and Refractive Surgery. And the technique is quite simple. You want to fixate the trailing haptic before the leading haptic. First, you want to place the IOL through a superior incision, and you're using a microforceps through an inferior incision contralaterally. As a surgical technician advances the plunger, you want to grab the leading haptic at the tip and with the microforceps, and as a surgical technician advances the IOL, you have to externalize the leading haptic through the inferior limbal incision. Now, this does several things. One, this secures the IOL from falling into the vitreous space. Two, this maintains the IOL optic in the more anterior position for easier needle haptic fixation. And three, this enables needle fixation of the trailing haptic first, which bypasses the most difficult step. Then I like to use the 30 gauge thin wall needle with a cotton tip, and I'm going to tunnel 2 millimeters parallel to the limbus and then puncture through the sclera, and this is 2 millimeters posterior to the limbus. And you can see there's a little loop of the trailing haptic right at the incision. This is a really neat trick because you can just grab it with the microforceps just like that in the perfect position and then start threading the haptic through the needle. So that's another tip, is keep that little loop through the superior 3 millimeter incision in that kind of U-shaped configuration, and grab the elbow of the haptic with the microforceps, and that easily grabs the haptic in perfect position so you can start to slide the haptic through the needle. Remember, you want to bend your needle in such a way that the bevel is going to face the approach of the haptic. I always like to secure my needle to a 1 cc syringe, so after I fixate it, I have to release the syringe from the needle. And while I'm holding the needle with my right hand, I'm going to internalize the leading haptic with the microforceps, and then using the assistance of a cotton tip and the 30 gauge thin walled needle, I'm going to puncture and then tunnel 2 millimeters parallel to the limbus, and then puncture through the sclera. Again, it's puncturing 2 millimeters posterior to the limbus, and these marks were pre-placed 180 degrees apart. And then you go ahead and fixate the leading haptic with the needle. Now, why is this such a beneficial technique? Because the trailing haptic is the most challenging part to fixate. So by externalizing the leading haptic outside of the eye through a limbal incision, you're able to fixate the trailing haptic first and bypass the most difficult step. So this makes the procedure much easier. I like to perform sequential externalization of the haptic and then create a small terminal bulb and then perform the same thing. I always like to hold the forceps right where the needle is being pulled out to be able to grab that haptic in just the right position so it doesn't inadvertently slip back into the eye. And then I'm going to use, again, cautery to create a similarly sized bulb. As you can see, the marks really help the centration of the lens implant. And then use the forceps to push the haptics into the eye and pushing the bulb flush to the sclera. So to summarize, the most difficult step with the original Yamane technique is fixating the trailing haptic, because the haptics are so rigid. After the leading haptic is fixated, the trailing haptic tends to drift out of view, and it's very difficult to grasp with micro forceps and thread through the needle. As a result, this modification externalizes the leading haptic through an inferior limbal incision, which is very different from the original technique, and this enables fixation of the IOL so it doesn't fall into the vitreous. It also holds the lens in a more anterior position for easier manipulation and fixation. And also, because you're fixating the trailing haptic first, that bypasses the most difficult step. I believe this simple yet new modification to the Yamane technique will make the surgery more approachable and less intimidating for the learning surgeon, and improves the ease, consistency, and reproducibility of the technique. I hope this was helpful to you, and thank you for your attention.